Okay, so I'm going to take us up to a little bit before 5, I hope, and I'm going to talk about just a bit of a survey of regulation of ketamine for psychiatric disorders. I have some disclosures. I've worked on advisory boards and educational work with Janssen, Sage, Lucis, and Allergan. And I run a ketamine clinic. We've seen about 300 patients, I suppose, for private patients and also NHS patients from Oxfordshire. Now, a couple of weeks ago, I had the good fortune to be involved in a workshop at which Paul Applebaum was talking about the ethical challenges of new antidepressants, rapidly acting antidepressants. Now, Paul Applebaum is a psychiatrist from New York, but he's really the doyen of capacity. He practically invented the idea of capacity. And he presented a series of challenges that I thought really nicely summarized the issues. The first one was about the generalizability of trials. Clinical trials are often not generalizable, but there are some specific issues that occur with psychiatric patients. Abuse potential is something we've been talking a bit about, and I'll say a bit more about. And then, of course, he talked about informed consent. And I think that there are a few issues about capacity that we do need to consider. He talked about the ethics of commercialization and the perverse incentives that there can be, and also about the ethics of fair access. And very wisely, I thought, he said, ethical challenges are not a reason to avoid use, but they do require careful attention. And I'd just like to talk about, obviously, ethics. The practical implication of ethics can be of regulation, and that quite often means mandating data collection of some sort or other. So to start with the first one of those, the main issue about generalizability is obviously that one really needs to understand the risk and benefit that the patient sitting in front of you in the real world is at. The ideal way of being able to maximize generalizability would be to have some sort of diagnostic biomarker, so you could really pick out your patient population, but we just don't have those in mental health, and in my view, it's going to be quite a while before we do. At phase 3, one of the key issues about generalizability is, of course, the exclusion criteria that are applied, and companies very obviously apply these mainly at the behest of the FDA and the regulators to improve sample homogeneity. But when one excludes patients who are suicidal or have a history of substance misuse or comorbidities, then the results of the trial have rather less applicability to the real world. And of course, if you say that actually these characteristics should be included in one's phase 3 study, then the size and cost of those studies will go up as the sample heterogeneity increases. And that is a barrier to innovation. And I'll talk just a little bit more about sample size and innovation later. So really the bulk of the work on trying to generalize the results of studies comes from comes in phase 4 after licensure in the form of safety studies or open label extensions. And we heard from Carla Canuso yesterday about the SUSTAIN 3 study, the longer term esketamine study. But it's also the case that companies are required in the years after licensure to submit safety data to the regulator on a regular basis. You'll be familiar with the yellow card, or in America, the MedWatch systems, where adverse events are recorded, but not that's all in a responsive way. And then, of course, there are other ways in which one can collect data through surveys of one sort or another. For example, attendance at casualty that Adam referred to. And he also talked about some of this data on the second of Paul Applebaum's challenges, abuse potential. And as Adam said, there are very few dependent addicts, and those who are frequency and dose are obviously the main issues, particularly frequency. We're seeing the rise in ketamine use up, so just over 3% of 16 to 24-year-olds are have used ketamine in the last year. And of those who've used ketamine for recreational or indeed self-treatment, 1 in 5 would like to use less. And ketamine is by and large a pretty safe drug. You can see here from this work from Dave Nutt that they looked at the physical harm and plotted it against, or dependence and plotted against physical harm. And you can see there's a tight correlation between the two. And in this presentation, it just looks as if ketamine falls into roughly the same sort of ballpark as tobacco, alcohol, and benzodiazepines. And that feels about right to me as somebody using it clinically. In terms of this analysis, looks at the overall harms that arise from all sorts of causes of a different range of substances with abuse potential, from alcohol on the left to psilocybin on the right, ketamine pretty much bang in the middle, with the bulk of its harms arising really from its immediate drug-specific sort of impairments. So the harms really not arising there in this analysis primarily from long-term use, from long-term harms, although of course there are the harms of cystitis and so forth. But how does this actually relate to medical use? Well, here the best data on tolerance and on tolerance is really from the SUSTAIN 2 study. This is the 1-year data that's been published. And here in the left-hand panel, what we can see is the MADRS data that has shown a rapid decline in the induction phase, but then the benefit seems to remain pretty constant over the next 11 months. So there's no obvious increase in dose and no obvious worsening of the response over that period. Now, I have to say that doesn't entirely tally with what I see in the ketamine clinic, and there may be all sorts of reasons for that that we can discuss later, but my patients' graphs all look a good deal more stormier than that, if I can put it like that. Maybe I'm doing something wrong. But what I really wanted to say was that there's a distinction between the tolerance to the benefit, there not being any tolerance to the benefit, and there being tolerance to dissociation. Now, this is pretty unusual, I would have thought. And so I think that we have to just keep an open mind about whether this is exactly how things are going to pan out in the real world. Obviously, these patients in the trial, they can't take more than 84 milligrams a week. There are all sorts of restrictions, and if they drop out, they can't come back in. So that obviously is a limitation. And I just want to say that again, in our practice, there are some. This is a bit of confessional, really, but these are the sorts of problems that we see. And we don't see them often, but these are flags that have been taken from the literature relating to opiate misuse. So the sorts of things that we have seen too are having little or scanty information from the previous doctor, where a common thing that we're finding is that people are asking an online doctor to refer to our service. So they're finding somebody who doesn't really know them and then getting a referral. And that probably reflects their frustration and falling out with their existing doctors. We've certainly had people who are uninterested in any alternatives. And if I have said to them, I'm sorry, I can't help you, they say, well, where can I get psilocybin? But they're certainly not interested in having lithium or other neuroleptics. So, I mean, this is a small group. Some have had contact with street drug culture. Some have got current substance misuse when they're referred. And we've had a small number who've tried to find ketamine somewhere else, and who have also arrived. I've had some patients who've arrived from America saying that they're taking nasal S-ketamine that's been paid for by the insurance company, and they're also having ketamine top-ups because they regard the dose as being inadequate. And then during the follow-up phase, we've had people who've used higher than the prescribed doses on occasion. That's not very common, but in our practice, we allow patients to, some patients to have oral ketamine at home. And there are some patients who feel much better but ask for more drugs. We've had some patients who've genuinely spilled medication and somewhere one hasn't been quite so sure, and occasionally sort of chaotic and changing stories. And the regulatory sort of implication of this really is that having an experienced mental health team has really been the thing that has helped us to manage some of these things. But taking the drug in the clinic, having our pharmacy colleagues down on us and checking every dot and comma has been really helpful. We also only allow small quantities of drug to be dispensed from the clinic. So there are other regulatory levers that can be pulled. I mean, the most important of which is that ketamine is a Schedule II drug. It's Class B drugs, so these scheduling and classes are control the possession, supply, procurement, and then how one prescribes it and signs it out in books, that sort of thing. Then alongside that has gone the risk evaluation mitigation strategy. That's the terminology used in the States, and in the UK, the risk minimization plan that goes with Spravato, which means that every dose that's taken has to be logged, and that data is returned to the company. But the company have to pay for that, and they control the data. And this data is not interrogatable. So if I'm prescribing ketamine to somebody, I can't find out for sure whether they're actually taking S-ketamine somewhere else. And it doesn't contain, it doesn't have outcome data attached to it, although obviously Janssen are doing further studies. Now, as far as the informed consent goes, Paul Applebaum refers to perhaps the difficulty in describing non-ordinary experiences, which obviously would undermine one's ability to inform the consent process. There are a variety of resources that one can use for this. And some, obviously, being a professional and able to talk to patients are very important, and there are accredited training programs being run by the ASKP3, including a certification exam. And rather interestingly, the MAPS experiential elective is mandatory for people to qualify as MAPS therapists, and they have to have a personal experience of a facilitated non-ordinary state of consciousness practice. And that usually means some sort of breath work using hyperventilation. And that's a caricature of it, but that's what it involves. And then I want to just briefly touch on the difficult issue of coercion and capacity. What happens when people don't have capacity, and how does that impact on ketamine? So one of the most unpleasant parts of being a psychiatrist is that sometimes one has to put people on a section of the Mental Health Act, and coercion can be part of the issue. Now, Carla Caluso said yesterday that the biggest effect size of ketamine is in the sickest, and I think I can see some truth in that. And obviously, the one thing that we know is that people's attitudes towards their treatment is highly influenced by the context in which it happens, and this inevitably contributes to stigma. And then Paul Applebaum referred to the inability to weigh. So the difficulty in which, so this in the UK, this is capacity is regulated under the Mental Capacity Act, and defined as, in this particular item is defined as not understanding the consequences of not having treatment or the risks and benefits. And I mentioned that earlier. But I have certainly met plenty of patients who said something along the lines of, if I could get an hour's relief, I would take it. Now, when somebody says that to me, it sort of suggests to me that they're so desperate that they can't really think. And it's hard for them to think about life beyond depression. They can certainly know what will happen if they don't have ketamine. They understand that, but it's hard to think of what would happen if they do. That this is all slightly different from the psychiatric emergency issue, but obviously the inability to weigh is likely to manifest significantly in psychiatric emergencies, such as are envisaged in the label for the new label for the for Spravato. So this is the short-term treatment for rapid reduction of depressive symptoms, and so therefore it's rather inevitable that one's going to be treating people with ketamine who lack capacity. That's different from saying that they're not wanting to have the treatment. But I think that this is something that we need to consider. And then to Paul Applebaum's ethical dilemma about commercialization, I have feet in both camps, in that I have worked, both have a private patients come as well as the NHS, as I mentioned at the beginning. And about half of the referrals that get made to us, I don't end up seeing for an assessment. Often the diagnosis of treatment-resistant depression seems to have been distorted to fit the available treatment. But in my entire professional life, the only complaints, the formal complaints that I've ever had have been relating to people who I declined to treat with ketamine. So it's, I think the other things that I notice are that people in private practice it's easier to stop the drug if it's not working, because people don't want to pay for it anymore. And we outsource the psychotherapy, whereas patients who come into the NHS, they tend to require more, they have more frequent clinic visits. So there's obviously cost implications there. And then I'd just like to finish up a bit, or the final challenge was fair access. And in the UK, this is effectively effected through NICE, the National Institute for Clinical Excellence. They are, in fact, it's not the MHRA, it's not the initial people awarding the license that regulate access, it's NICE and the insurers in the US. Just for those of you who don't know, the NICE timetable for considering S-ketamine for treatment-resistant depression has actually had 3 rounds of consultation. That's a bit unusual. The last meeting was on the 11th of February and the decision is still awaited. That length of time is also a bit unusual. And part of the reason for that will be that there's a confidential negotiation on price that goes on. And this NICE regulates in England, Wales, and Northern Ireland, whereas the Scots have their own medicines consortium. And the Scots have, Scottish Medicine Consortium has said that Spravato should be available on the NHS. But unlike with NICE in Scotland, that isn't a mandate. It doesn't have to be made available by the NHS. It's guidance. Whereas for NICE, if they recommend it, then the local commissioning authorities have to pay for it. And these are the sorts of costs that are involved. So Spravato, its UK list price, and as I mentioned, that's not necessarily the NHS price, is about £489 per dose for 84 milligrams. And remember this, you start with twice weekly for a month, and then usually once a week or once a fortnight. And on that basis, the company has generated an assumed 12-month cost of £10,000 per trial. And that has resulted in a company analysis of the cost of per quality of £7,000. The draft NICE estimate of this was 55 to 62,000 pounds per QALY, and you have to get under 30,000 for it to be acceptable to NICE. So either the price will have to come down significantly, or something else will have to give, or it won't be made available in the NHS. The contrast here is with ketamine. So we typically get up to about 6 or 7 treatments out of one of these £8 vials. And ketamine is not itself it is itself a generic drug. So it's the mode of administration that's been licensed to Janssen. So one of the key things for NICE is that their data demands are different to those that are required for licensure. So, for example, they're particularly interested in whether the population being treated in the NHS is different to that in the trials. And this comes back to our generalizability issue. For example, might the NHS patients be more treatment resistant? Now, of course, what Carla told us yesterday was that the more treatment resistant patients actually do better than the patients who are less treatment resistant. So that's obviously important, but it's not there in the initial data. It's absolutely crucial to know how long the average course is, how long the average person will take this before stopping it. Whether the and in the modelling, it's very important to know whether the trials are whether the ketamine is whether the depression is episodic or not. We need to know what happens after treatment. So the lack of these data actually reduce access. So getting these data is really important. And I was delighted to see that in this recent the white Department of Health white paper that's been put before Parliament, published recently, right at the very end of it, had a little section saying we think that the MHRA ought to be able to mandate publicly funded registries that can include outcomes. And of course, if that could include off-label drugs, and it could include all rapidly acting drugs for affective disorders, and if it could be interrogatable, then this would be a great way of supporting early access schemes for rapid antidepressants. But it opens a further ethical issue. Should we be introducing in an early phase of real world use the idea that unless the patient contributes data, then they can't have a drug, because obviously we need to know what their symptoms are. So just to summarize, regulation often requires a data element to it. There's a wide range of regulation already in place, but we really need better data to support fair access, to compensate for poor generalizability, and ultimately we need it to reassure everybody. And the main issue here is stewardship of the drug. It would just be such a shame if our lack of data and lack of control on the drugs, particularly of unlicensed ketamine, was resulted in further stigma and restrictions. So this is best to happen in phase 4, and I'm hoping that new legislation might just do the trick. I've gone slightly over my time, and I apologize for that, but thank you for your attention. So we are going to start on time with the next session, which I think is going to be in just about 5 minutes' time. So do join us then. As I mentioned right at the beginning of today, in fact, what we're going to do, because Adam is unable to stay for the whole session, is we're going to have all speakers in the same session, and you don't need to go to a breakout room, so don't go looking for one. Just stay exactly where you are, and then we'll have a panel of all today's speakers. And then towards the end of the session, and we've got as much as an hour and a half if we need it, we will address your questions. We will explain the answers to your questions that have been given to us by Paul Glue, who did a talk on ketamine and anxiety disorders yesterday, and Sai-Ying Wang, whose talk on postpartum depression you heard a bit earlier. So look forward to seeing you in those sessions in now just a very few minutes. Thank you.